Now we're in America, in Connecticut and Boston. So I'm delighted to welcome you both. Would you like to introduce yourselves and tell us a bit about your paper, please?
Sure. So first off, thank you for the invitation. I think this is really exciting and an awesome way for us to showcase our work. My name's Janine Blake. I'm a PhD candidate at the University of Massachusetts Amherst with the College of Nursing and the Institute for Applied Life Sciences. I am a nurse, and the bulk of my bedside career has been spent in the intensive care unit. Dr. Karen Giuliano is my mentor at UMass Amherst, and since she's here, I'm going to let her introduce herself.
Yeah, so thank you. Janine and I have been working together since she entered the doctoral program. I'm an associate professor at the University of Massachusetts. It's a joint appointment between the Institute for Applied Life Sciences and the College of Nursing, and also the co-director of the very brand new, just formed Nursing and Engineering Center for Innovation, which we'll talk about a little bit later.
Do you want to just take us through briefly what your paper was about and the title and maybe the key points?
Sure. So our paper is called Extending Tubing to Place Intravenous Smart Pumps Outside of Patient Rooms During COVID-19, an innovation that increases medication dead volume and risk to patients. We were very fortunate to get to work with 3 co-authors who have pretty prominent roles in the IV medication safety space. So Robert Butterfield is an engineer and an IV smart pump expert. We also got to work with Tim Vanderveen, who's a pharmacist with expertise in IV smart pump safety, and Nat Sims, who is an anesthesiologist and the inventor of the IV smart pump dose error reduction system. So COVID-19 really pushed us to change a lot of practices and innovate in ways that we hadn't before. And moving IV smart pumps was a way for us to decrease PPE use and to decrease clinician exposure. So it can seem like an obvious decision, but once you dive into it, there's a lot of safety implications that we really have to think about. And this needs to come from the entire care team, which is part of the reason why we were so eager to publish in BMJ Innovations, because we really feel like this is a space that should have some recognition and some education across care areas and across providers. So a couple of the main issues that we see with moving pumps outside of patient rooms, despite all of the benefits that we as clinicians can gain from it, we really have to look at the patient safety. So there's a few issues related to the pressure that extended tubing can cause. It can cause decreased flow accuracy, but that wasn't the main point of this article. We really wanted to highlight another aspect that we really need to pay attention to when we're using this practice, and that is dead volume. So dead volume is the space or the volume held in tubing between the pump and the patient. And as you can imagine, when we extend tubing 10, 20, 30 feet in order to move those pumps outside of patient rooms, that dead volume is significantly increased. And that can mean retained residual medication. As nurses, we're the first to really recognize when a therapeutic response is not met, right? We need to have a recognition of when that might happen, when it might not be met, when we expect it to. Those are all really important things for us to pay attention to. From the pharmacy perspective, dosage, concentrations, flush volumes for secondary medications, all of those things need to be considered when ordering and when dispensing the medication. And then ordering providers need to pay attention to how they're choosing to change rates, how they're choosing what venous access devices to be used. And we really wanted to start the conversation about that.
Yeah, fantastic. One of the reasons we're interested in publishing it is because it's a great example of a great idea, light bulb moment thing, but actually when you get to the bedside and you have the experience of people at the bedside, then issues become obvious around safety and practical application of things.
We also don't want to say that it's not a viable alternative, because it can be, but there's 2 things to consider: all the practical implications or the clinical safety implications that Janine mentioned, and also it's an opportunity for manufacturers to think about their technologies, how it impacts these safety, and to use that as material to help them innovate. So I think because it does solve some problems, but also creates problems, as most things we do.
So maybe now's a good moment to talk a bit more broadly about what your research group is doing.
Yeah, absolutely. So although this article is a review article, it's informed by work that we and our co-authors have collaborated on. But we have a big program of research coming up involving flow accuracy. And that's when I said the rate that the patient receives is different than what is actually displayed on the pump. And as an ICU nurse, it wasn't until I really started reading about, well, especially Dr. Giuliano's research, that I realized that as a nurse, I relied on technology.
And so nurses and engineers are actually remarkably similar. Both are trained problem solvers and both have to rely on innovation to find solutions. But despite these, they're in the natural setting, their paths rarely cross. So I came to UMass because we had the opportunity to really bring these two disciplines together in a very important way and to develop the center. And this is really going to allow nurses and engineers to really effectively and quickly test and develop innovations that require both of our skill sets. And the power of the nursing and engineering approach is really derived from this mutual collaboration.
So I'm really pleased to say we're joined by one of our peer reviewers, Claire Hepworth. So Claire, would you like to introduce yourself?
Hi, yes, my name is Claire Hepworth and I'm a nurse in Nottingham. I'm currently working in governance and I've got particular interest in error. Until a couple of months ago, I was working in critical care and I've been doing that since 1995. I also ran for several years a partnership with Hospital in Ethiopia, which is relevant because of the resource settings. You have to innovate a lot with equipment and repurpose things. So I was particularly interested to see this, and I've been working clinically during the pandemic. So it's very interesting to see how other people approach the challenges of this.
That's great. We don't usually do this with manuscripts, introduce peer reviewers to authors, but everyone has agreed that it's a great idea to have a bit of a discussion. So thank you all for agreeing to participate. Perhaps, Claire, you could say what your sort of first impressions of the first draft were and what suggestions you sent back to the authors.
Okay, so I was very interested to read it. It leapt off the page as an interesting adaptation to a challenge in practice. And I think, as you'd mentioned, Janine, it's one of those things, it looks intuitively incredibly appealing, but when you dig a little bit, all sorts of problems become apparent. And I thought you'd done a very good, clear job of breaking down where those problems lay, and
Thank you.
particularly dead space volumes being a massive issue. I was also I very much liked the way you had examined it from a multidisciplinary perspective. I think that is so often lacking in papers, and it was just nice to read the inputs of the really important team members.
Thank you. I am really glad that came across. That was when we were outlining the paper from the beginning. I mean, that's really what we wanted to get across. So thank you. I'm glad that it did.
I think that really worked. There were so many points of error that were becoming apparent. And I think also in the background of the pressures of a pandemic, when people are dealing with increased pressures, probably reduced staffing, increased stress, it just seemed that there were so many points of error. I think I'd wanted you, when I read the manuscript initially, just to raise the profile of that and highlight that even more clearly. I was also interested if this is something you had experience of using in practice. It's not something I'd come across in the UK, and I was just interested to see had you used it and how it had worked for you. So I think I fed back a combination of those comments. I think I'd asked for a table just summarising the different risks from multiple MDT perspectives. I think that was a really useful reference tool for people reading the paper, and I was really pleased to see that in there.
And your comments were excellent. Every time we get reviewer comments, our work improves. And I loved your suggestion for a table. It's actually something that we've used in past articles. So I jumped right on that. I love that suggestion. I think we ended up adding a little bit more information about the use of moving pumps outside the patient rooms, but it wasn't something that I had done myself. And I added a little case study. I don't know if it was suggested by yourself or our other reviewer to add a case study example. I talked about my experience caring for a very, very sick COVID-19 patient and not moving pumps outside the patient room. And it gave me some understanding about how the decision could be challenging, because I absolutely can see how it could improve a workflow. But we really have to keep in mind the implications to patient safety, and that by mitigating those and by making informed decisions, we can decrease that risk, at least in part. And it's always a risk versus reward balance.
So Karen, have you got anything to add to the discussion?
Yeah, first of all, thank you very much. I've been writing now for quite some time, and I've really come to appreciate how important peer review is, because when you study something, you're passionate. Otherwise you wouldn't be studying it. And that passion easily can lead to tunnel vision and some narrow-minded views. And I found the peer reviews always help to say, oh yeah, should have thought of that. Oh yeah. And it's kind of funny because just recently I got a peer review that had, I think, more comments in the reviews than I actually had words in the paper. So it all doesn't necessarily get easier, even though I've been doing this for a long time. But you just take a step back, and just say, you know what, they're doing it for the right reason. And so at the end of the day, and plus you're gonna have a better piece of work for yourself as trying to develop your own scholarship. But even more importantly, you're going to have a better piece of work for your readers to disseminate this knowledge.
Great, thank you. Claire, have you got any other comments about the process of being a peer reviewer? Was it straightforward for you?
Because it's so relevant to my practice, I really enjoyed looking at the issues in more depth.
And you'd be happy to peer review again? That's my leading question.
Absolutely, yes. Yes.
Fantastic.
Thank you so much for the time and effort that you put into it, because it helps the readers, and again, it helps us a lot.
And it's not a small feat.
Well, thank you all so much for agreeing to talk to each other and with each other. It's been really great to get you all together.